So welcome to this evening's ACP Problem Solving in Oncology webinar series. My name is Dr. Daniel Hughes. I'm chair of the ACP Trainees Committee and also registrar in medical oncology within the UCL rotation, and I'll be chairing this evening's session. This evening's webinar will provide you an overview of immunotherapy toxicities, including diagnosis, investigation, and management, with plenty of opportunity for discussion. The educational content of this evening's meeting are entirely non-promotional, but we are proud to have our webinar series sponsored by Eisai and Roche, both world leaders in oncology pharmaceuticals. Our webinars are recorded and will be made available on the EBN Health ACP Library website within a couple of weeks. This is free for all ACP members, and you can also access all the ACP Problem Solving in Oncology book series via that website. So without further ado, it's my pleasure to welcome and introduce our panelists for this evening. We have two excellent panelists with two trainee cases, which generates lots of discussion. Our first panelist is Dr. Ricky Frazer, consultant medical oncologist at the Velindre Cancer Centre in Cardiff, who specialises in both renal cancer and melanoma. Dr. Frazer has also been instrumental in setting up and running a very successful acute oncology service in South Wales, with a particular interest in immuno-oncology toxicities. Our second panelist and first speaker of this evening is Dr. Anna Olsson-Brown, consultant medical oncologist at Clatterbridge Cancer Centre in Liverpool, who specialises in the treatment of both melanoma and sarcoma. Dr. Olsson-Brown also undertook her PhD on the topic of immunotoxicities, as well as setting up and establishing an immunotherapy toxicity service at the Clatterbridge and regional area. This evening, Anna will be providing us with an overview of immunotherapy toxicities, which will be followed by a panelist discussion around the management and challenges of immunotoxicities. So without further ado, Anna, when you're ready, please go ahead and share your slides.
So I will go ahead and talk you through some information about immunotherapy toxicity. So I think it's always useful to set the scene about immunotherapy. So for tonight, I'm going to essentially focus on the toxicities caused by checkpoint inhibitors. Obviously, we know the immunotherapy world is expanding at pace, and sooner rather than later, it's likely that this will extend to things that aren't checkpoint inhibitors. But for the moment, we'll talk specifically about checkpoint inhibitor toxicity. Now, as we know, the utility of checkpoint inhibitors has changed very radically in the last 5 years. And from what used to be a small group of melanoma patients with metastatic disease being treated is now extended into over 15 different tumour groups, with new tumour groups coming into use fairly regularly. And also the immunotherapy world has moved from very much being a palliative treatment to being featured in the adjuvant setting, with trials also in the neoadjuvant setting. So we are really advancing into the utility of these agents. They are becoming a cornerstone of treatment across multiple different tumour groups. But actually the experience within those tumour groups of these treatments is still very variable. Some who've been using these treatments now for years, and others who have really in the early stages of utilising these treatments in the standard of care setting. And that brings with it a very real challenge in terms of the immunotherapy toxicities. Not only are we having experience with different degrees of experience within oncology, but also the awareness of immunotherapy agents to the outside world and beyond oncology within medicine actually is still very variable and quite limited. So it is starting to feature on the national scene with regards to different specialty groups, but it is still very much in its infancy. And so really we are still really at the beginning of how we manage these treatments and these toxicities, and it's an ever-growing area. So tonight I'm going to specifically focus on immune-related adverse events that happen as a result of checkpoint inhibitor treatment. And I'm sure, as everybody's aware, the way that checkpoint inhibitors work is they inhibit checkpoint proteins, which allows dysregulation and reactivation, if you like, of CD8 T cells, which essentially allow cytotoxic cell target of different malignancies and induced cancer cell death as a result of that increased activity. We think that the non-specific dysregulation that is caused by checkpoint inhibitor blockade actually means that there is an overactivity of T cells against other tissues, and actually probably recognition of self-antigens, which means that we get lots of different organ systems targeted by these agents in terms of side effects. And it would be very fair to say that actually literally any tissue or organ system can be affected as a result of an immune-related adverse event. And it is to some degree completely unpredictable at the moment. Now we are getting closer to understanding the background between immune-related adverse events and why they might happen, but we're still a long way away from being able to predict what and to what degree patients are going to get toxicity. So at the moment, it's very much any of these are possible, and if there is a patient that's presenting with an inflammatory type condition and they've had a checkpoint inhibitor, it is very reasonable to assume that it may well be the checkpoint inhibitor that's causing the problem. And in terms of the sort of the frequency and incidence of the toxicities we see grade 3-4, so we still use the CTCAE criteria. So grade 3-4 requiring a hospital review or admission happens in anywhere between 1 in 5 and 1 in 2 patients receiving checkpoint inhibitors. So we are seeing a lot of people through our doors who have got toxicity from these drugs. What and when does it happen? So this is some data from our local Liverpool cohort, and you can see that actually across different tumour groups we see very similar toxicities, and the most common things we see are colitis, skin toxicities, hepatitis, endocrinopathies are the mainstay of things that we see, but increasingly seeing more pneumonitis, more arthralgia, and other more rare, in inverted commas, toxicities are becoming more commonplace the more and more immunotherapies that we're using in more and more different tumour groups and broader groups of patients. In terms of when do these side effects happen, we see side effects happening right from the first treatment all the way through to up to 2 or 3 years after discontinuation of checkpoint inhibitors. So it is very variable. Basically, any time is a consideration for a checkpoint inhibitor. The timing of it does neither include or exclude it being a checkpoint inhibitor-induced toxicity. And certainly, cycle 1 toxicity is not unheard of and increasingly something that we do see. Also worth being aware of the fact that if you compare combination dual checkpoint inhibitor treatment to monotherapy, that tends to be more severe, but actually happens early in a treatment course. People can die of immune checkpoint inhibitors in terms of their toxicity, and the things that we worry about the most in reality are pneumonitis and myocarditis, which carry the highest mortality rates. Other things do carry a mortality rate, although they tend to be lower, and as we get more experience at recognising things, actually the mortality rates are falling overall. Why and how is immune therapy toxicity different from chemotherapy? Interestingly, I think this is the one key piece of information for oncology and non-oncology services, that it is different, and it's different because you need to do something about it. So it's all down to the mechanism of the drug. So the drugs stimulate T cells, they have no interaction with the tumour itself, and once you've dysregulated the T cells, you actually have no way of re-regulating it in terms of removal of the treatment. So the T cells become overactive, and there is a perpetuating cycle of inflammation that is very unlikely and cannot really spontaneously terminate. So actually you end up needing to do that for it via the use of immunosuppression, which we'll talk more about in just a second. But also the way the treatment's given, it's given for long-term treatment, anywhere between 1 year and 2 years is standard, and you can see the toxicities long after you've stopped the treatment. So actually it's just a very different beast to other systemic anti-cancer therapy, and if you withdraw the drug, you don't stop the toxicity. Interestingly, if you give more drug, you can make the toxicity worse. So hallmarks of immune-related adverse events: patients often have vague symptoms. They will say things like, I just don't feel right, or this just doesn't feel quite like it did last week. So getting an understanding of the pattern of the change is really important. Sometimes patients feel completely well and they have only biochemical disturbance. The toxicities rarely resolve on their own for that self-perpetuating cycle that we talk about, so actually they often need immunosuppression. And it used to be that we just sort of described a reluctance of patients to report immune-related adverse events. Increasingly, it's become clear that actually it's not necessarily a reluctance, more a lack of awareness that that is indeed what's happening. So they quite often go into ED or primary care with very vague symptoms. We do know that there can be long and drawn-out management requirements for these toxicities, and the reflare is common, and we'll talk more about that in a little while. Withdrawal of the drug doesn't lead to resolution of the toxicity, and because of the way that the drugs bind with their receptors, dose reductions don't, generally speaking, help. We think there is a dose toxicity relationship, but we haven't quantified it in terms of pharmacokinetics yet. I think once you understand the mechanism of treatment, you can understand why the toxicities happen and why the treatment strategies are needed, but it is very different from chemotherapy and SACT, as we've talked about. These patients need regular follow-up, and I'll explain more about that in a moment. And as I said before, there are no clear predisposing factors, although there are cohorts that are increasingly becoming recognised at higher risk, such as those with pre-existing autoimmune disease. The first thing to know is there are protocols everywhere to help you manage these patients. So actually don't worry about managing them. There are international protocols, and generally speaking, we within the UK reach for the ESMO protocols. There are also some national protocols that are co-produced by the UCONS Society, and they're embedded in the initial management guidelines. There are also local protocols. Most areas will have their own local protocols, or they will actively use UCONS or ESMO's protocols. These are just the ones that we use in Clatterbridge, and we use a traffic light system with a very clear layout of the toxicity management. The other thing is that there are some standard steroid tapering guidance, and it's really part of the key features of managing these patients, and the UCONS guidelines also outline this really nicely. The ASCO guidelines, which we use less commonly in the UK, but have recently been updated just this last month, and has a really nice section on the management of steroid-induced side effects, which is really worth a look at. I always say remember to clinically evaluate the patient, because it's very easy to give steroids, not do investigations, not think about differentials. So it's one of those really difficult balances to strike, where you need to always think about immunotherapy as being a potential, but always make sure that you're excluding other causes as well, which is obviously a big ask, but really actually important. It's actually quite simple to treat these patients, at least in the first instance when they're first presenting with their toxicities, and essentially they follow a mild, moderate and severe process, which will either mean they don't need any active treatment, which is very rare, but moderate symptoms require oral steroids, normally in the form of prednisolone, and normally at a starting dose of 60 milligrams once daily, but there are different protocols that outline that for you. And then if a patient has a severe toxicity, actually they probably need some degree of IV steroids and possibly additional immunosuppression. But these protocols generally lay it out really nicely, so it's easy to follow. I like to think about the management of immune-related adverse events in terms of a toxicity cycle, because this allows you to understand that patients can cycle through this process more than once in their treatment, and also that we always need to think about the malignancy and what we're doing in terms of treatment at the end of it. So there's something about identification, and if the registrar, as a registrar or consultant on call, you may get calls from other areas, from local AMUs or EDs, about the fact that there's a possible patient that's got this. Also, patients ringing hotlines with potential side effects. How you identify these patients, how you then get them in for review, where do you get them to review? Patients don't necessarily all need to go to emergency departments out of hours. There is some centres that are stratifying patients, and actually a daytime review the next day may well be sufficient. So really worth understanding what your local protocols and policies look like for that. But all patients need a review. The decision about what immunosuppression is needed, they start on immunosuppression. And the thing that's really worth being aware of is the fact that normally short, sharp doses of steroids don't really help or completely get rid of terminate the toxicity in immune-related adverse events. And patients will need some degree of steroid weaning, which is why the steroid weaning protocols are so important, because otherwise everybody does it slightly differently, and you don't really understand where you're up to, and you don't have sort of a sort of backbone to understand what hasn't worked. The patients then need monitoring, and again, different teams and different centres do this differently, but it is really important to make sure the patient isn't re-flaring, because otherwise what happens is they carry on down their journey, they take their steroids, and then they're re-flaring, and then they re-present as an emergency. So some process to monitor the patient's improvement is really key. And then once the treatment, the toxicity is resolved, it's actually quite important to make sure you haven't given them a steroid-induced hyperadrenalism. So actually checking that their cortisol function has recovered after you've finished high-dose steroids is really important. And then you need to make sure you're reviewing what's happening with their malignancy and the treatment you're going to give them for that, whether that's reintroduction of the immunotherapy or a switch to another agent or a process to best supportive care. Any of those things are reasonable, but they all need consideration and part of this toxicity cycle. And as I said, patients can traverse through this cycle more than once during their treatment, because what happens is patient feels very well, they get a toxicity, you make that toxicity better, they continue to be very well, then they'll get another toxicity. So it's a very episodic process that patients aren't, generally speaking, that ready for, and find quite difficult, because they feel really well and then suddenly they don't feel very well anymore, and they feel like they've failed or they were doing really well before, and it's difficult to navigate from a psychological perspective. So warning patients up front that this is probably what's going to happen if they do get a side effect really helps when it happens, and it helps them tolerate hospital admissions, IV steroids, etc. Do we need to see these side effects forever? Are they always going to be a part of checkpoint inhibitor treatment? It's difficult to know. Certainly there are studies that are trying and limit this to some degree, and this was a trial that is a phase 2 trial that was presented by Jeffrey Webber from the States back at ESMO this year, that basically looked at a very small cohort, but could they give an anti-IL-6 agent alongside ipilimumab and nivolumab and maintain efficacy but actually limit toxicity. And very early days and very small cohort, but would suggest that actually we do reduce down the side effects, although still we were getting patients that were having grade 3-4 toxicity, although the numbers much less, with some retained efficacy. So this is a very early study in small numbers, but we are on the way to try and understanding whether we can indeed try and design studies and design treatments that don't necessarily have such a high degree of toxicity burden. Patient assessment. So these are my points about how to assess a patient who's potentially got toxicity. What's normal for the patient, really important. How long have they been on treatment is worth being aware. What's the duration and pattern of symptoms, continuous versus intermittent? Has it progressively got worse? That's really important and quite commonly associated with the immune-related adverse events. We are increasingly using combination therapies, and I'm not going to go too much into the rationale behind that, but understanding the tempo of toxicity really helps us separate what's the driving feature. So if patients are on combinations and you take the drugs away and the toxicity gets better, generally speaking, you're looking at a chemotherapy or a TKI-induced toxicity, whereas if you take the drug away, the immunotherapy toxicity, generally speaking, continues. So understanding the tempo of toxicity and also what happens when you remove a drug actually really helps us understand what's causing what. Have there been recent new medications that are actually the cause of toxicity, and what were the previous medical conditions, and are we causing a flare of those? So what questions do we ask? So we ask really specific questions, and I think that's one of the really take-home messages of tonight is don't ask vague questions, particularly as we're now assessing patients over the telephone. Patients, generally speaking, will want to reassure you that they're well and will be fairly non-specific if you ask non-specific questions. So actually, increasingly what we've learned when we're assessing these patients is you have to ask very specific questions, and you have to really push them for details. And if you do that, you will get a much better picture of their toxicity. And always consider what's normal for the patient. Is this a new symptom? Has it been happening over the last few days to weeks? Really important in things like fatigue. Patients might feel a little bit tired on immune checkpoint inhibitors, but if they've got new, really significant fatigue, that's really important. And I'll talk a little bit more about that in a moment. But actually understanding whether that's new and abnormal for the patient is really, really key. If I put that into perspective for you, I had a patient who used to swim 60 lengths every 3 times a week. And she rang and said, I feel a bit tired. I can only swim 20 lengths 3 times a week, which actually didn't sound like too bad, really, and probably better than I could do. However, she actually had a complete hypophysitis and a cortisol of 20. So really important to understand what that patient does normally and whether there's been changes, even if they don't seem too specific at the time. I would say there are 10 principles to the management of immunotherapy toxicity, and they're laid out here. So I'll spend a little bit of time just going through them. So really take notice of vague symptoms and investigate fatigue. Patients, generally speaking, are well with these treatments until they're really, really not well. So a well patient doesn't mean that there isn't anything going on. A blood test and a symptomatic review can rule out toxicity, and an expanded blood panel is standard, including a random glucose and an endocrine panel, such as TFTs and cortisol, are really important and very helpful in ruling out problems. Treat the severest parameter. So if patients look really well, but they're having their bowels open 8 times a day, or they've got an AST of over 1,000, these are important things and should be treated as such. A well patient is not as reassuring as maybe it should be. Monitor. One of the things that's really key with IO toxicity is that the toxicity tempo is much quicker than an endogenous problem. So, for example, a patient can go from having a completely normal thyroid to being hyper and then hypothyroid in the space of about 10 days. That would normally take at least 6 weeks in the world of normal endocrinology. So we are seeing things happen much more quickly, probably because we're supercharging our T cells. So the specialists that look after the endogenous conditions are sometimes somewhat skeptical about the speed that these things can change, but having seen a lot of this now, it's absolutely a feature. Know your local national protocols. If you follow the protocol, it will lead to sort of the institution of treatment relatively easily. We treat with high doses of steroids early, and I'll show you some evidence as to why that's important in a moment. Really essential to reach out to medical specialists, not necessarily acutely. It is important if there are existing medical specialists who understand this and have been working with your oncology centres. They are a fountain of knowledge and really, really good to work with. But there are also increasing numbers of subspecialists of oncologists who have an interest with toxicity, and there's certainly 2 of them on the call tonight. So, there is a small but ever increasing network of individuals who are interested in this, and actually it's becoming quite clear that actually you need that, and we're happy to support. If the steroids aren't working, add in another immunosuppression, and we'll talk a little bit later about what you choose and why you choose it, and ensure the side effects of management are recognised, particularly the side effects of steroids, again, something we'll touch on in a little while. As I've spoken about IO and chemo or IO and TKI combinations, it's all about tempo and recognition of whether a toxicity looks to be a standard toxicity or not. So I'm going to talk a little bit about some specific toxicities for a short period. So initially, myocarditis. So myocarditis has, generally speaking, been relatively under-recognised, we think, and it's previously thought to be a very rare toxicity. Increasingly, we're finding more and more patients with it. The more we look for it, the more we find it. And just to put that into perspective, we did a review of 105 patients who had baseline troponins and pro-BNPs, and then had serial testing when they presented with symptoms of either shortness of breath or fatigue, and we noticed that 6 of those had MRI proven myocarditis, which is a frequency of around 5%. So that's a small number, so it may actually be slightly over recognizing, but certainly it's not the rare beast that we initially thought. In terms of the way that myocarditis presents, it can present with any of these features, but not all patients will present with everything. Some will have normal troponins, some will have normal ECGs, and some will have normal pro-BNPs. But actually, it's a cluster of symptoms associated with what can be considered vague symptoms, but normally fatigue is a really interesting one and something that we're increasingly taking notice of. And this is an interesting slide that shows you that actually high-dose steroids given early makes an absolutely massive difference compared to low-dose steroids given in a delayed fashion. You can see here the difference in significant cardiac event-free survival is very significant, and the higher dose of steroids you give, the better the outcome. Just to touch on colitis, essentially colitis has been a learning experience for us and the gastroenterologists. They, generally speaking, have fairly moderately exciting scopes, but their histology is much more interesting, and interestingly also about 25% of people get a collagenous or T-cell type colitis. So it's really important to get scopes, and we'll talk a little bit more about why, but actually it really helps guide treatment and also confirm the diagnosis. So just a few questions that I think to be aware of that are coming through. So at the moment, we use infliximab as our first line after steroids. There's a question about whether we should be using other agents such as vedolizumab, which is an anti-integrin agent. So again, this may be something that changes relatively soon, but infliximab is what we use at the moment. How much do we give? That's up for discussion, and we'll talk a little bit more about that after one of our cases. And where do we go after infliximab? And there's a whole host of different agents we could be using, and increasingly we're realizing that we do actually need a second line post-steroid agent, and probably this is quite specific to the individual patients, but again, we'll talk a little bit more about this after the cases. Pneumonitis, it was considered to be fairly uncommon. I think it's been difficult during COVID, but actually we are seeing a very distinct pneumonitis pattern. And actually they, generally speaking, really do require high doses of methylprednisolone early. And again, sort of that 2 milligram per kilogram, 4 milligram per kilogram of methylpred is something that increasingly teams are using. We do use other agents such as MMF, and there is some increasing evidence for infliximab or IVIG, which hasn't been used in existing ILD circles. So we're trying to get to the point where we've got a decent amount of evidence in this area, because it's a little bit of an evidence-free zone. Certainly, we need to exclude PCP infection. We also need to try and exclude that it's not a bacterial infection, and the use of procalcitonin is increasing, and also excluding fungal infections by checking things like beta-glucan and galactomannan can be helpful. So they are a difficult group to treat, and often I think the one thing about pneumonitis is it probably is the slowest to respond. So normally IO toxicities respond quite quickly with immunosuppression. Pneumonitis often takes a bit longer, and patients can require oxygen for a while. If you are seeing an improvement, that actually is probably enough, and you need to continue with immunosuppression for maybe a bit longer. So our protocols often say between 3 and 5 days of IV steroids. Sometimes patients with pneumonitis need a bit longer. And just say there is a prospective trial that is being run in patients who aren't responding to steroids, comparing IVIG to infliximab to see if actually we can understand which one of these is a better agent. And I think this is really interesting because it's one of the first prospective studies in this group, and that's really important as we need more of these. And they are slowly starting to evolve as the community in the UK becomes aware of the fact that we really want prospective studies to understand where we go next. We can use consensus statements. We do use consensus statements, but we're trying to move away from that as time goes on and get a proper evidence base in this field. Fatigue is one of the things I really want to mention. So cancer patients are normally fatigued. We're used to seeing fatigue. People on chemotherapy feel fatigued. Fatigue in immunotherapy patients often has a reversible cause. We do need to rule out endocrinopathies. We're much less likely to have anemia as a consequence of treatment, although we do see iron deficiency anemia quite frequently. And the therapy itself causes significant fatigue, and this is the minority of cases. So realistically, we shouldn't see a lot of fatigue. So we have in Liverpool now, we now do a fatigue screen, which looks at various different elements. And actually, we found that fatigue is one of the main presenting complaints of myocarditis. So if people have had a fatigue screen that's negative, and they have continued to feel significantly fatigued, we are increasingly doing a TROP, a CK, and a pro-BNP, as it seems to be quite a useful marker for myocarditis. Obviously always consider progressive disease, but actually increasingly we are investigating these patients and seeing reversible causes in many. Endocrinopathy is really worth being aware of the fact because they are very insidious and often quite hard to recognise, because that is one of the ones that really falls into that vague category. We see any gland affected. You can see new type 1 diabetes presenting as DKE, hypothyroidism, hypophysitis, hypoadrenalism. So basically anything is key, and actually having a fairly strong indication to investigate if you find a patient who is presenting sort of with nebulous symptoms is really helpful. Endocrinopathies are the one toxicity that don't really reverse. Everything else you treat with high dose steroids, and generally speaking they get better. Endocrinopathies, it appears that we cause glandular burnout quite early on in the toxicity, and so they generally speaking need replacement rather than steroids to reverse, and normally their toxicity is permanent. I have seen a few reverse and go back to normal function, but it's really very rare. Worth thinking about hypogonadism, particularly in males, because they can feel very fatigued, and testosterone is an easy fix if that is indeed what's going on. This is just to say hepatitis can present in any manner. It can be a transaminitis. There are patients who present with very obstructive pictures, particularly with disproportionately high bilirubins, and that can also be an immune-mediated hepatitis. The highest bilirubin I've seen from an immune-mediated hepatitis is 560, which reversed back to completely normal with treatment. So you can see any picture. Any of these are possibly the case. They are predominantly transaminitises, but it doesn't completely rule out hyperbilirubinemia as a result of IO-induced hepatitis. Skin toxicities is one of the things we see most frequently, and most things are lichenoid reactions with PD-1 or PD-L1 inhibitors, much more commonly to get sort of a morbilliform rash or a typical drug reaction rash with a CTLA-4 inhibitor. They generally speaking need slightly lower doses of steroids, so they respond really well to 30 milligrams of prednisolone orally quite often. It is really useful to get a biopsy, and we do see more abnormal and bizarre toxicities such as SGS, TEN, and pemphigoid, and they do need slightly different treatments post steroids if you don't get a response. So again, worth liaising with your dermatologist to think about whether you use things like cyclosporin or methotrexate. We are realising that late effects is a thing. It's becoming a more noted thing. There's a really nice paper from March this year looking at the chronic immune-related adverse events, and actually you can see that actually they're quite high. And also I think it's always worth being aware that grade 2 toxicity can actually be quite significant in terms of quality of life. So there are a few late effects clinics being set up around the country. We have one here in Liverpool, but we are going to see more of this, and understanding how we work with our primary care and secondary care specialist colleagues to manage this is something we really need to think about going forward. Just a couple more slides. I want to talk about, can we separate toxicity and efficacy? This has been a really big topic of conversation, and anecdotally we've said to patients for years that we think there's probably a role of the fact that if you get toxicity, then you're more likely to get a response. Actually, more and more data coming through that actually that is the case. This is in the case of melanoma across 2 cohorts, one in Oxford and one in Liverpool, and you can see that the top line, there's a clear separation of the curves, and the top line of patients that are getting toxicity on their overall survival. Really important to notice that these were clinically significant toxicity, so these were also receiving high dose steroids plus or minus additional immunosuppression. So even with that on board, they still have a better overall survival tendency. And just this last slide, which was done in collaboration with the Notch collaboration, looking at the effect of age on toxicity, and the survival curves here overlay each other, so you can see that age doesn't actually seem to impact on survival. However, it does impact. It also doesn't necessarily impact on toxicity. So they do get slightly more grade 2 toxicity, but people over the age of 75 don't get any more significant toxicity in terms of grade 3, 4 toxicity and admission rate. So actually, they're one of the few treatments that don't appear to be negatively affected by age, think is really important for us going forward. There is always research going on. I would encourage you to get involved. There'll be more as we go along, looking at both quality of life and also and what treatments we use. And there is, if you're interested, an immuno-oncology game to help go through the management and treatment. And if you want to get one, you can just go to this website here. And I will stop there. Thank you very much.
Thanks, Anna. That was excellent and to time. So thank you very much. So, I mean, I think it's a very interesting comment you made about the late effects. I think that's going to definitely be more of a conversation moving forward and something we need to think about. A couple of questions coming in. There is one question about infliximab and colitis, which I'll hold on to until we discuss the colitis case. And so you discussed biochemical changes, and often that patients may present only with biochemical changes. With differences in cycle length, and particularly now we've got multiple indications for immunotherapy across tumor types, how often do you think we should be checking blood such as cortisol, TFTs? Should we be doing it every cycle, or should we be doing it at a specific interval?
I think that's a really good question, and one that there are no national or international guidelines about this. So the trials didn't really particularly play out in terms of giving us guidelines. We did, when we looked at changing from 3-weekly to 6-weekly cycles with the change in pembrolizumab, for a long time we did mid-cycle checks to see if we picked up any abnormalities. So we didn't seem to pick up any significant additional abnormalities. So I think 3 weeks is too frequently. We pick up quite a lot of asymptomatic toxicity 6-weekly. So I would say 6-weekly or before each cycle, if you're using 6-weekly cycles, seems to be reasonable. We are working with the UK Chemotherapy Board to actually put a guideline together on this, because we do need one. But I think that sort of length of time seems to be about the right duration.
Yeah, and you also mentioned about kind of risk with hepatitis, etc. Do you screen patients at baseline? Is that standard practice where you are?
So it's interesting. So we had a long conversation with our hepatology colleagues about whether we should be screening it. They felt that we should be doing a viral screen before treating. The amount of patients who have got viral induced problems that we reveal with checkpoint inhibitors is really limited. So we don't do a hepatitis screen. We do check everybody's LFTs, and we also do a cholesterol check, because one of the things that we've noticed over time is that most patients that get hepatitis, if they have imaging changes, it actually presents like fatty liver. Now, it's a phenomenon we also see in chemotherapy, where you get increased fatty liver as a result of treatment. But if we have got patients who have got high cholesterol, then they do seem to be at slightly higher risk of hepatitis. We're just trying to work on that to actually get some data to prove that. So we are treating patients who have got high cholesterol prior to starting immune checkpoint inhibitors, but we don't tend to do a viral screen because the numbers we pick up are very small. You can see reactivation of hepatitis, for example. I've seen 2 in all of the patients that we've treated, so it's quite rare.
Thanks. I just mentioned that because there are some UK Chemotherapy Board guidelines coming out very shortly about testing for hepatitis in all patients with SAC, so something to keep in mind. There's another question about myocarditis, which again I'm going to hold on to until we discuss the case, and then one more question about fertility. So can immunotherapy affect fertility?
So we think so, yes, certainly. So the number of patients that seem to get an isolated hypergonadism is actually quite high, a lot higher than we initially thought. So the number of young people we're treating with checkpoint inhibitors up until relatively recently was quite low, but certainly we do think it can affect fertility. Now, there's a bit of a discussion between ourselves and the endocrinologists. The endocrinologists feel because it's a direct hormone issue that actually if you replace the hormones, we may actually be able to preserve fertility. But we certainly feel like this is a really big area of potential challenge. Certainly been working with colleagues at the Marsden to try and understand whether we need to set up a clinic or at least a trial to understand how many people certainly treated, both male and females, whether they should be fertility preserved or not. There is a very heterogeneous practice around the country as to whether we offer fertility preservation for those who want it prior to treatment with the checkpoint inhibitors, and it's probably about a 50-50 split as to those who offer it and those that don't. Increasingly, I'm erring towards the side of saying we should offer it if somebody wants it, because we cannot be sure, and we certainly do cause other endocrine problems, so infertility is quite likely to be on there as well.
Okay, great. And there was just one quick question about asking where we can find the guidelines for management. Is that UConn you mentioned the website?
So there are a number. So I would say it's always really worth checking what your trust does locally or your region does locally, because quite a lot of regions have gone to the effort of creating their own. And the reason that's useful is because often they've got sort of guidelines to the right people and things. If not, there are options. So if you want a UK-based guideline, you can Google ours at Clatterbridge. There are UConn's guidelines, which are really easy to use, or the ESMO guidelines. They all essentially say very similar things.
Okay, great, thanks. I think we'll move on to the trainee cases and come back to those questions on myocarditis and colitis during those. So we're going to move on to the first trainee case, which is going to be delivered by Elisavet, who I believe is from Sheffield. So Elisavet, when you're ready, if you share your slides and you can go ahead.
So yes, thank you, Dan. So my name is Elisavet, and I'm a clinical research fellow from Sheffield. And thank you very much for giving me the opportunity to present this case that I came across when I was doing my urology rotation. So it's a 69-year-old lady who presented in April 2020 with a palpable abdominal mass, and investigations showed that she had 10 centimeters right renal mass with possible lung metastasis. So the biopsy that she had from the renal mass confirmed clear cell renal cell cancer. So in terms of past medical history, she had a left ventricular septal defect that didn't need any treatment, high blood pressure on amlodipine, cervical spine arthritis, and she didn't have any autoimmune disease. She is a retired architect, lives alone, and she's a lifelong non-smoker, and she doesn't drink alcohol. First time we saw her at Olsson-Brown Hospital was in May 2020, fit and well lady with performance status of 0. And in terms of symptoms from her disease, she only reported occasional pains. Her IMDC score was 1, and so she had an intermediate risk disease. So in review of the COVID-19 pandemic, unfortunately, we couldn't offer her nivolumab, ipilimumab as a first-line treatment. So she was really keen to have treatment, this lady. So as the first line, she had pazopanib, which unfortunately stopped after first cycle due to liver toxicity. It was switched to sunitinib, which again stopped after 3 cycles due to fatigue. Her scans that time show stable disease, and she was really keen to carry on with treatment, but she didn't really want any TKI. She was she really wanted to have immunotherapy, and after very long discussions, multiple discussions we had with her, we agreed to start second line nivolumab ipilimumab, which she had the combination phase with no particular problems. She was started on low dose of thyroxine for mild hypothyroidism. But 3 weeks after the completion of the combination phase, she presented with grade 2 diarrhea and colitis. She had mucus and blood in her stools. So at that point, she was started on prednisolone 1 milligram per kilogram. In terms of her blood test and the stool samples, they were all negative. Nothing really remarkable to report there. And she, at that point, also she was referred for a colonoscopy. So the colonoscopy did confirm immune-related colitis, and at that point we agreed to continue her steroids as she was doing better. But when gradually she
yeah, that's fine. And we've got some answers on the screen. So the result of the poll, so we've got 30% answering increased prednisolone dose to 1 mg per kilogram, around 23% saying the second answer, so increased dose and refer from infliximab, and the majority saying switch to IV methylpred.
Yeah. So what we did at that point was we increased the steroid dose, and also as per the gastroenterology team, this lady had 2 doses of infliximab, which eventually helped her to come off her steroids. She was on steroid for almost 3 months, this lady. So throughout this episode, she did not require any hospital admission. And after she finished her steroids and came off her steroids, she was well with no symptoms. She did not have any GI symptoms. So we saw her back at Western Park at that point. She was free from GI symptoms, but she could not cope well psychologically with the fact that she was not on any treatment for her metastatic disease. So my next question would be, what will you offer to this patient at that point? So watch and wait, given the fact that she's well, carry on with monotherapy, nivolumab, offer her TKI or lenvatinib, everolimus, or something else.
The responses are, so you've got 50% answering watch and wait, 32% nivolumab monotherapy, and a couple of others for the other options.
Other options, okay. So as department, we agree for this lady to continue with the nivolumab. We thought that point that maybe the ipilimumab would have been the cause of her symptoms more than the nivolumab. The patient was really, really keen to carry on with her immunotherapy. She was adamant to me that she wanted it. She was fully aware about the risk. So she went ahead with the nivolumab, but unfortunately, after the first dose, her GI symptoms came back, and she was restarted on prednisolone with a more gradual reduction of the dose this time. She did not require any infliximab and no hospital admission. In terms of her scans and her disease, initially she had some partial response to immunotherapy, but then further scans show stable disease. As far as I know, this lady now is well and she's off steroids, and I don't think she's on any treatment at the minute. So in terms of discussion, when is it safe, if at all, to restart immunotherapy after immune-related toxicities? How do we manage the steroid refractory colitis, and maybe where do we go after the infliximab, and how do we deal with these patients that they really want this treatment but they have serious side effects? Thank you very much.
And yeah, so when's it safe to re-challenge? And I think it's really, first of all, it's about weighing it up with the patient, because the patient needs to understand that if you're going to re-challenge with immunotherapy, there's going to be the risk that you're going to flare the toxicity back up. That's the starting place for me, is always to have that conversation with the patient. I think there's a few things, and I'd be keen to see what Anna does in her practice. There's a few things that I use to guide me. So I would always get a scan and see if they were responding. And if the patient's responding on the scan, I'm often quite comfortable to stop for a period of time and see if they've had the response they need, and therefore if they don't actually need to be re-challenged at all. And then I think it depends a little bit on the toxicity. So, we know that colitis is primarily a CTLA-4 toxicity. So it's primarily an ipilimumab side effect in this context. And so we've got fairly big retrospective data sets that show that if you just re-challenge somebody with nivolumab, actually less than 10% of patients will get a flare of their colitis. Clearly it can happen, and I think it happened here with a slight flare. So, if you think about pneumonitis, which is slightly different, pneumonitis tends to be a PD-1 side effect, a little bit more than CTLA-4, and so I'd be less keen on re-challenging with a PD-1 for pneumonitis. So I think it comes down to patients understanding the pros and cons. It depends a little bit on if you're responding. If they're responding, I would probably sit tight and see what happens in terms of not needing any more treatment. And then I think it also depends on what we think is driving the toxicity, if we think it's the CTLA-4 or the nivolumab. Anna, any thoughts?
Yeah, so I think that's really true, and in what we generally speaking find both in basically any tumor group that's treated with combination, which is slightly increasing, that it's very unlikely for a patient to tolerate all 4 cycles of combination. There are a few, but it's quite uncommon. And so sort of the first rule of thumb, rather than never restarting, is certainly sort of our standard practice. If we've managed to resolve the toxicity, that we would just drop the ipilimumab earlier and carry on with the nivolumab. I do agree that understanding the response to that, to those initial immunotherapy, is actually really helpful, because it allows you to be a bit more person specific in the way that you approach it. So if you know that they're responding, it gives you a bit of extra time. Generally speaking, because we don't know the optimum amount of immunotherapy, and in reality, because it's a modulation of a person's immune system, it's likely to be quite variable patient to patient. If you see a response, you can actually sort of discuss whether you should restart at all. If you don't see a response or it's a bit mixed, then you're probably a bit more keen, particularly if you see that toxicity very early on, to restart treatment. So I think understanding the response is really important. I would say as standard, we would knock the ipilimumab off early if we had a patient who had combination toxicity that you've managed to resolve. And some patients don't necessarily need to restart at all, but by and large, most people would want to, and I think increasingly we are getting to the point where we can restart. I think there's a question that we don't have an answer to yet at the moment in terms of understanding whether you should cover a patient with a certain amount of immunosuppression when you are restarting. So you are allowed to give up to 10 milligrams of prednisolone alongside the immunotherapy. Now, whether you should or not is really currently out for discussion, and we probably need some real world data to understand whether that's actually an effective thing to do or not. One of the things I thought was quite interesting when you were presenting it was about what the histology actually showed. So there is an increasing body of data that suggests that patients who get colitis, actually the minority of them get UC-like colitis on histology, which is where we used to think everybody was. And there is a high number of patients that get either collagenous or microscopic colitis. That's really helpful in knowing, because they tend to respond less well to systemic prednisolone and IV methylprednisolone, but respond very well to localized topical bowel therapy by either using budesonide or modified release, something called Clipper, so that actually we know that we can use a steroid that has got less systemic side effects but still has the optimal effect in the bowel. So increasingly, certainly within Liverpool, if somebody has collagenous colitis, we will treat them with budesonide in the first line rather than jumping in. We would switch them quite early if that's what their scope showed. The other thing I think is interesting about your case is that you gave her 2 cycles of infliximab and she got better. There is some data coming out of Mimi Wang's group at the MD Anderson that shows that actually if you give up to 3 cycles of infliximab, you get more mucosal healing. So they've done scopes at the point of colitis and post infliximab 2 or 3 cycles, and shown that actually the likelihood of reflare is significantly reduced if you get proper mucosal healing. So actually, one of the questions I think again for us as a community is, do we give enough infliximab to resolve the colitis, or do we actually give 3 cycles as standard, is a question that we're currently trying to answer.
Anna, if I can just come up with a couple of points that you mentioned. So that topical budesonide originally confused me. I think my understanding is that we're giving oral budesonide, but it's topical because of the first pass metabolism. I had this idea that maybe it was rectal, and that's why we called it topical.
Yeah, no, absolutely. So it is still oral tablets, but because budesonide is, I think it's 95% metabolized by first pass metabolism, you just get a topical effect. You don't get any systemic effect or side effects. Now, it is worth being aware that it's a little bit variable patient to patient. So some people will have enough systemic effect to suppress their cortisols and others won't. So it's something just to take into consideration when, if you suddenly get somebody who's had a cortisol taken and they're on budesonide, it may be that's suppressing it, but it's about a 95% first pass metabolism.
And I think the other thing just worth mentioning about the scope is, there's several reasons why a scope is so important. So one of them is if you see ulcers when you do a scope, actually, they're often patients, I don't know if you found this, Anna, that tend to be quite steroid refractory. So that's quite useful to know. And also, we do know there's a small percentage of patients who will have CMV colitis. And so being able to biopsy and look for inclusion bodies can be really useful to make sure we don't miss that diagnosis.
Yeah, absolutely. For all of those reasons, we definitely find so. There's a paper that we published in the British Journal, BJC, British Journal of Cancer, looking at the presence of ulceration, and absolutely they should get infliximab relatively quickly. So it's been interesting with COVID. I don't know if you found this, Ricky, that there's quite a lot of there's issues in endoscopy, issues getting access to endoscopy, but there are definitely, we're now talking to our gastroenterologists and they've encouraged us to go back to requesting scopes on everybody. And that's been really gratefully received, because we've had to sort of understand the pattern, and sort of there are certain patterns that sort of lend themselves to thinking about whether it's collagenous or microscopic, but also that kind of early indication for ulcers to get infliximab in early. It's much easier if you can do endoscopy. So I think there is a reluctance, but actually it really helps us understand what the colitis we're dealing with, because it isn't all the same picture. And I think we've historically put them all into the same bag, and then they're not.
So I think Dan's about to tell us off for going on too long. So I'm just going to say
I
one
think he
more thing. The
Not
other
at
thing,
all. I know you've got lots more to talk about. So
just the other thing to mention to people is, you know, increasingly, I think the fecal calprotectin can be quite useful as a marker of generalized inflammation. And not only does it tell you that something's going on, it also gets your gastroenterologists excited because this is their kind of currency they like to hear about. And the other two things that I now routinely test for is thinking about doing a celiac screen and thinking about checking pancreatic enzymes, because it's very easy to develop things like pancreatic insufficiency. So things like fecal elastase is worth screening for. So just other things to think about for GI toxicity.
Yeah, we absolutely do those as well. And it's, for celiacs, it's worth being aware of the fact that it's quite often an antibody negative celiac. So it looks like it on scope. And we think it's probably an IL-15 driven pathway. So it isn't always auto-antibody positive. So absolutely agree with that. And fecal calprotectin is probably the only biochemical marker of colitis that's useful in IO colitis. CRPs are fairly useless. Albumin is fairly useless, but fecal calprotectin both is useful if it's high, and actually is actually quite a good way of tracking whether the colitis is improving. It does also tell you about response as well as presence of inflammation. So we certainly use it a lot, and we do serial testing as sort of a marker of response.
That's great. Thanks very much, both. Those are really important points. So, Paolo, when you're ready, we'll hand over to you to present your case.
Okay, so my name is Paolo. I'm one of the ST3s at the Royal Marsden. I would like to present the case of a lady who is currently an inpatient with us in Chelsea. So it's a lady who has been quite unlucky and has had a number of immune-related adverse events affecting multiple systems, and which have been high-grade and recurrent in some cases. She is being treated with immune checkpoint inhibition for her non-small cell lung cancer, and the good news is that her disease is currently well controlled. So the background: she's a 77-year-old lady. She's a quite run-of-the-mill case of squamous cell carcinoma of the lung. She has a PD-1. She's a high PD-1 expressor with no actionable mutations. She is a current smoker with a heavy exposure to smoking in the past. She's got COPD and she's got a host of other comorbidities. Importantly, she has no evidence of previous rheumatological or in any way autoimmune diseases. Unfortunately, her pulmonary function test precluded radical radiotherapy. Therefore, she was treated with saline pembrolizumab, and she had 2 doses administered in mid-May and then the second cycle in late June. The first toxicity that she had was biochemical hyperthyroidism, from which she was totally asymptomatic. She unfortunately ended up in hospital a few weeks later. So she came in to our clinical assessment unit with grade 3 diarrhea, going maybe 8 to 10 times a day. When she came to ASCAU, she had an ECG, and there was some T-wave inversion in V1 and V2. Therefore, the CAU staff thought about adding on a troponin, and we accidentally found out that the troponin was raised at 667. She was an inpatient with us for 1 week, and she received a pulse of IV methylprednisolone, so 1 gram once daily. And she recovered quite quickly. She underwent the investigations listed before. In particular, she had normal left ventricular ejection fraction on the echocardiogram. The cardiac MRI didn't show any edema or inflammation, but did show some regional wall motion abnormalities. And in terms of restaging, her disease was perfectly stable. In particular, it was the only measurable disease was her primary lung cancer. She had a coronary angiogram which didn't show any evidence of coronary artery disease, and when she went home, her diarrhea had resolved. The troponin was much closer to normal values, and her repeat TFTs 6 weeks from the previous ones show instead, in this case, a biochemical hypothyroidism, which was again totally asymptomatic, and she was starting on levothyroxine at this point. A couple of weeks later, she had finished her taper regime oral prednisolone, and her troponin was almost normal at this point. I had a telephone consultation with her a couple of weeks ago. At that point, she mentioned that her diarrhea had reappeared after a couple of weeks of being well. She was going 3-4 times a day. She didn't have any cardiac symptoms, no breathlessness, no edema, no funny turns. And she had had a lower respiratory tract infection for a couple of days. She had received her third COVID vaccine 1 week prior. She hadn't received any antibiotics in the community up to this point. While I was making my plan, the bloods done in clinic came back, and unfortunately, some of them did not come back immediately, but the ALT came back at 492. So I think I have a poll now. Okay, it's quite interesting that so it seems like 2/3 of people would do the same thing that we did. So we felt that with an ALT of 500, which we felt was either due to immune-related hepatitis or to progression of disease, we would be best suited to look after her in our cancer center rather than sending her to A&E. And of course, the other the other options are inappropriate with a grade 3 ALT rise. Moving on. So she ended up with us, and I gave this plan to our CAU staff. So in our unit, CAU is mainly staffed by AMPs. So I called them and said, this is my differential diagnosis, that this is the plan. So I thought she had grade 3 hepatitis, and she should have a hepatitis screen stool samples for her low-grade presumed colitis. She should have some repeat imaging, particularly of her abdomen, and I hadn't seen any troponins or BMP coming back from the previous review in clinic. And I thought the diagnosis would be of hepatitis grade 3 triggered by her checkpoint inhibitor. The patient was very well and only had very, very mild cough and grade 1 diarrhea, and didn't quite understand what this major fuss was about. Her repeat staging showed that the lymph nodes which were previously present in the chest had disappeared, and the left upper lobe was primary was stable, and the troponin came back at 1020. So what would you done at this point? One more poll. So I think we all pretty much agree that such a high troponin rise, even in the absence of symptoms, is quite serious. So I would rate this as a high grade presumed myocarditis, and same-day echocardiogram, same-day cardiology consult on the serial ECGs and troponins to exclude alternative pathologies such as myocardial infarction would be indicated and are probably part of your local guidelines. Yes, next slide. So she is still with us on the ward. She was seen by acute oncology and cardio oncology on the first team, and she went to CCU for cardiac monitoring. Bedside echo wasn't particularly excited. The unexpected finding was that she was COVID positive. That was probably related to her very, very mild lower respiratory tract infection that she mentioned in clinic. So this complicated things a little bit because we wanted to use quite high grade immunosuppression, but we were quite scared about doing that in somebody with a mild COVID infection, but still having COVID. Therefore, we said we just in RMDT we decided not to give MMF or any other secondary immunosuppressant quite yet, and just hold on tight with steroids. She was given a single dose of these monoclonal antibiotics for her COVID. She went back to the ward a couple of days later. Troponin LT was nicely falling at this point, and then we managed to step the steroids down to 1 mg per kg after 6 days pause. And we added on MF at this time because troponin and LFT had stalled. She went on to have the cardiac MRI, which was delayed because she was COVID positive at discharge, and she would have only been able to go when she was COVID negative. And these, unfortunately, again, didn't show what we were hoping to find, which is edema inflammation. So she had what is probably an old MI and very little else to look at, and cardio-onc advised to get a cardiac PET CT, and we thought about sending a rheumatological panel. Again, there was very, very minimal activity in the apex, which was deemed to be non-specific, and again, no convincing features of active myocarditis. Her rheumatological panel has now come back, and she's ANA positive, and she's got an anti-ROD antibody, which is usually seen in either congenital lupus or Sjogren's. So we are trying to get hold of rheumatology. We are going to offer her a flexisigmoidoscopy as soon as possible and take a hysterectomy in the next few weeks. She has been rediscussed today in Oncology MDT, and she's got lots of topics, so we'll start a beta blocker. We were very, very interested in getting a biopsy, but unfortunately, our cardiology colleagues are not keen. And this is the trend of her markers, in particular the troponin and ALT. Both of the markers are measured in international units. As you see, there is an initial very good response with pulse IV metipred, and then started MMF, and then there is a further decline. In terms of the points that I would like to discuss from this case, this lady has had pretty much all of the immune-related adverse events that you can possibly think about. She's got an endocrinopathy, she's got colitis, which we are trying to confirm on histopathology. We presume that she has had a grade 3 hepatitis, and we think she has had true episodes of myocarditis. She has had minimal immune checkpoint inhibitor exposure. She only had 2 cycles, and yet she has achieved a quite good response with the disappearance of the lymphadenopathy, the mediastinal lymphadenopathy, and stable primary tumor. I'm not sure we are 100% sure that this is indeed myocarditis, whether COVID was just an incidental passenger there, or whether it did play a role. And in view of the rheumatological panel, we wonder whether this could be something slightly different, as, for example, a vasculitic process. Thank you very much for your attention.
I think this is almost certainly immunotherapy-induced myocarditis, and COVID might have played a role.
Thank you.
It's a pleasure. So isn't it interesting? So I had 2 questions. One is, did you ever check this lady's CK, or was it only troponins? And the other one was, you said her PD-L1 expression was more than 60%. Do you know how much more?
I'm afraid so. I'm not sure how lucky you are in Liverpool, but here at the Marsden, we only get, for some of our patients who are diagnosed in external centres, you only get more than 50, and you don't get 95, 90, 85, and so forth. So I'm afraid that's the answer to the second question. I don't think we got CKs at any point. Are you thinking that she might have had a myositis?
Yeah, I think it's quite interesting. So your rheumatoid panel is an interesting one, and I think it depends a little bit on. So ANAs can be weakly positive and not mean anything. So it depends on how positive is, and the anterior antibodies don't really necessarily fit with this picture. So I think it's difficult with autoantibody screens, and you're absolutely right to get a rheumatological opinion. But what we do know is there are certain numbers of patients who have pre-existing subclinical autoantibodies that don't do anything and may never do anything. And when we dysregulate them with checkpoints, that actually they've developed clinical manifestations. So that's certainly the case in reported cases of myasthenia gravis, for example. I think she's really interesting. I'm really pleased you started MMF, because I think in reality, this lady's never going to get away from being on steroids unless you start a second immunosuppression, because no matter how many times you give high dose steroids, she seems to respond really nicely. And then actually, as you reduce down the steroid burden, you're clearly not completely reversing the inflammation, because then she flares when she's on low doses. So I think in reality, to get this lady off steroids before she's horrendously Cushingoid, you're going to need a second and possibly a third agent. One of the things I think is quite interesting is she had both colitis and myocarditis at the presentation of her first sort of significant toxicity. So you could have thought earlier about using something like infliximab, which is useful in both of those settings, to give you a bit of an anti-cytokine element, which might have sort of helped things. That's one thing to maybe think about. It's always difficult when you've got a patient with hepatitis, because there's some documented evidence within the IBD setting that if you use infliximab, that can induce hepatitis. There's a really nice paper that came out in gastroenterology about 2 months ago that actually shows patients with hepatitis being given infliximab, and none of them get worsening hepatitis, and quite a lot of them respond. So I think we have been long concerned about using infliximab in hepatitis, and maybe we don't need to be. My only other thought in terms of the myocarditis and the issues with cardiac MRI is the fact that she's got fibrosis on that scan would potentially be suggestive of that might be the myocarditis that you saw first, that actually the edema had resolved and the fibrosis is left behind. It's non-specific and patchy, which is actually quite classic from myocarditis. Also, the fact that you'd given her quite a lot of steroid, and you were very much on it. You recognised that she had myocarditis very early. You saw her troponins and you started really high dose steroids. In reality, I'd be quite surprised to see good going edema with a biochemical response with a week's delay. So certain literature will say that you see changes up to 6 weeks after starting steroids, but I think that's normally in patients who the myocarditis hasn't been quite so readily detected. So you basically went from a lady who didn't have myocarditis to one that did very quickly over the course of a couple of days, having biochemically resolved previously, and treated it very effectively. And it may be that actually the reason you're not seeing a sort of imaging proven myocarditis, actually you've been very good at sort of detecting it. The same reason that potentially with colitis, if you scope them really early, you see fairly patchy and non-specific changes, because actually they haven't had the weeks of lead-in that you would do in a traditional IBD. So I think there's something about imaging. I agree, an endomyocardial biopsy would be very interesting to see if you've got T-cell infiltration there. But you probably won't get one. I agree with that too. But I think it's quite interesting. But it's difficult, I think, for us going forward and throughout the last year, the impact of COVID on detection and management of IO toxicity has been very difficult. The recovery study with the dexamethasone being helpful has been incredibly helpful, because in reality, it kind of becomes an academic point as opposed to a clinically needed point. You treat them very similarly. But I think it's possible that and we know that the toxicities that we see from IO and some of the side effects we see from COVID are very, very similar to one another, and that's probably related to the impact of the virus on T cells and the checkpoint inhibitors in relation to T cells. But either way, even if you've got a COVID element in here, this lady is highly likely to have multiple side effects from her ICI. And I think given the fact that we know there's some nice data from the Notch data set that actually the higher the PD-L1 expression, the more associated that is with toxicity. That's why I asked about whether she had really high PD-L1 expression, because it's not a case of if you've got 100% expression, you'll definitely get toxicity, but it is seen in more patients with higher PD-L1 expressions, particularly that early 1 to 2 cycle tox that we've seen in this lady.
Thank you, Anna. I wonder, with regard to the fact that you would have liked to start MMF as soon as possible, the fact that she had COVID, would it have scared you as well?
Not necessarily. I think I'm not necessarily sure that you needed to start it any earlier. I think, once you've got a lady, probably when she had a thyroiditis, a colitis and a myocarditis before she had COVID, I probably would have thought about starting something then, rather than relying on steroids. And that's really changed over the last 4 to 6 months. So, our reliance on steroids has been long standing, and actually the use of immunosuppression actually still feels relatively uncomfortable. But I think it's fine to have waited while she gets over a COVID before you start the MMF, but I think it's very unlikely that she will get off steroids without some form of immunosuppression, and it might be that MMF alone might not be enough.
And regarding what you said about the cardiac MRI and the fact that we are probably not seeing things because it has already been treated to a degree, yes, we were desperate to get that MRI before, but they were just adamant that unless she had several negative PCRs, there was no way she was going to have any imaging. And
in reality, I don't know if Ricky agrees, for me that is it doesn't stop you treating her because she's responding biochemically and from a rhythm perspective. If you give her steroids and you're tempering down her immune response, she's getting better. So the MRI findings are nice to have, but I wouldn't say this isn't a myocarditis because she didn't have MRI findings in this case. So it's we have to work within the parameters of life at the moment, and they're a bit more tricky than they might have been previously.
I'll just answer a question which was in the chat. So we did the rheumatological panel on the day that MRI came back as not myocarditis, because we started thinking about, okay, this could be something funny. Let's do a few more tests.
I suspect the more you look for this lady, the more you'll find, but actually it's probably just ICI-induced overdrive from very small amounts of treatment.
Thanks very much, everyone. I think in the interest of time, we'll move on, because I know there's a few interesting discussion points to touch upon. Thanks very much, Paolo. Is a really good case. So I'm going to hand over to Ricky and Anna, who are going to discuss some other aspects and challenges in a discussion type session. So I don't know who wants to start first, but we've got about 15 minutes perhaps for this section.
Yeah. And Anna, I was just going to say, before we do that, shall we just answer some of the questions in the chat? So I know what it's like to be in the audience and not get your question answered. So
yeah.
So there's a question here, if we just go back and forth. So there's a question here about immunotherapy in transplant patients. Do you want to start on that one and then I'll pick up?
Certainly. So I treat all skin cancers, including metastatic SCC. So I see quite a number of patients who've been transplanted and had immunosuppression and got cutaneous SCC as a secondary malignancy. And I have treated them with cemiplimab, and they have done quite well. So there is certainly a role for immunotherapy in patients with transplant. We certainly wouldn't stop their anti-transplant medication. I've been asked that question previously. It's interesting, transplant patients are generally maintained on really low levels of immunosuppression. So normally it's a fairly low dose of prednisolone and a bit of MMF. Normally, there are some that are also on tacrolimus, but it certainly is something we've done, and we've done successfully. It depends a little bit on how actively you can monitor them. I would say that actually we monitor their renal function, particularly if we're thinking about renal transplant, but also can think about liver transplant patients, particularly with HCC patients coming on board. So we have to monitor them very closely, and they have to be quite hyper reactive to changes. And normally they will eventually you will find some changes in their function. So we, generally speaking, have stopped with a relatively low threshold, but actually interestingly we've seen really good responses. So you do have to counsel the patient very strongly about the fact that they might lose their transplant. You also have to talk quite extensively with their transplantee, for whichever organ they've been transplanted for. And I certainly have warned my patients about the fact that they may end up needing dialysis if we go down this route. But in reality, if it's a palliative, so I would steer away from it in the adjuvant setting, I have to be honest. If they have got a metastatic cancer that is with a relatively poor prognosis, in reality, they have got quite a lot to gain from being treated with checkpoint inhibitors. So it depends a little bit on the patient's circumstances, what cancer they've got, and how stable their transplant is. But certainly you can, and I have treated patients with transplant with success. Yeah. So if I throw one back to you, Ricky, does that sound okay? So in terms of, there's a question here about pre-existing autoimmune disease. So it'd be interesting to hear what your thoughts are about how you manage these patients, and whether you do think about prophylactic treatment, or what you do with their existing immunosuppression.
Yeah, so I think there's 2 points I would make. So the first thing is I will always have a conversation with the patient and ask them how bad it ever got with their condition. So with rheumatoid arthritis, some patients will say it was the worst thing I ever experienced. And some people will say my joints were a bit sore, but it was okay. And so I think that's really important to know how bad it ever got, because it may get back to that point. And so that's always the first thing I do. I'm actually quite comfortable running the immunosuppression alongside the immunotherapy. So I don't tend to stop them if they're on low dose steroids, or if they're on a low dose of another immunosuppressive agent. I'm quite comfortable running the checkpoint inhibitor alongside it. But what I do is I write to that specialist before I get started and say, here's what I'm going to do. It's likely things are going to flare up. Can you be in close contact? Can we have a plan B ready for if things go wrong? So I guess my 3 points would be that I will always find out from the patient how bad it ever got. I'm quite comfortable running the immunosuppression alongside it, but I will definitely get the specialist involved early.
Perfect. Great stuff.
I think there was one more question. I just want to make sure everyone gets their questions answered.
I think it was about keeping patients on low doses of prednisolone and continuing with immunotherapy. So you happy for me to take that one?
Yeah.
So yes, the short answer is yes. The slightly more protracted answer is it depends why you're doing it and who you're doing it for. So there are certain patients who really struggle off steroids completely, but you can maintain on a low dose of sort of 5 milligrams, or if it's an arthralgia, even 1 milligram of pred, surprisingly makes a big difference. So as long you are allowed to, as long as you're starting them on 10 as long as you're on 10 milligrams of prednisolone or less. Now, if you're sort of in your first run at it and they haven't flared, then I tend to bring them off completely. If you've got a patient that recurrently flares at very low doses of steroids, then absolutely, if you feel from an oncological perspective they need more checkpoint inhibitor, then you can and are allowed to, and I do, start patients and maintain them on a low dose of steroid. And then depending on how they're doing and what their toxicity is doing, I will either stick with that for the foreseeable, or I will wean them much more slowly. But certainly I do, and I'm very comfortable to maintain that lower dose. And I think that comes back to the fact that we've got increasing data that suggests that patients who are on immunosuppression still respond if they're responding. So actually you can be fairly sure that a bit of steroid probably isn't going to do you any disservice. And the same for, there are some patients who you can think about restarting on sort of other immunosuppression as long as their toxicity is completely resolved. So yes, I would. Okay, so I think we've got about maybe 5 to 10 minutes left for some chat. So Ricky and I were just going to sort of pass a few questions that we thought were quite pertinent around. So I think I'll start by asking Ricky about what you do with patients who recurrently flare, and what your approach to them is.
Yeah, so I think these are a challenging group, and I think I'm still learning on the best way to manage these patients. So I'm by no means a master at doing this. I think the first thing is to look how quickly you came down on the steroids the first time. So we've all got patients, and certainly the more experience you get, there's always this tendency of, can I get down a bit quicker than I normally do? So particularly with hepatitis, I get the feeling that we probably overtreat hepatitis in terms of the steroid doses that we're using. And so I've started to either, come down quite quickly, or even think, can I sit tight for a week and repeat the LFTs? But the problem with that is that sometimes I come down too quickly and things flare really quickly afterwards. So I guess the simple answer is, it's really about using the guidelines because they're there for a reason. So, coming down by 10 milligrams every 5 to 7 days, most of the guidelines would articulate something fairly similar to that. But if people flare, and you particularly see this with pneumonitis, I find this is a real challenge. You get down to 10 or 20, and then you might get a flare back up. I would either then come down much slower the next time, or I've got more of a tendency to add in a second immunosuppressive and try and get off the steroids.
So that I would echo that completely. I tend to have a rule of thumb of you sort of like, it's sort of a similar rule to seizures. You're allowed one, but after that, not so great. So one flare, I would probably persevere with some steroids and maybe sort of elongate the tail. But if you're getting to a second flare or actually a concomitant second toxicity, then I would be thinking about adding in a second agent much more much earlier in the treatment course than maybe I would have done historically.
And so, Anna, if you do that, then what do you do so let's say you added in, 500 BD of mycophenolate, for example. How quickly do you lose the steroids, and then how quickly do you get them off the mycophenolate?
So what I generally do is, and this is in our subsequent immunotherapy management guidelines on our Clatterbridge website, if you want to sort of review this afterwards, not you, the listeners, apologies, but essentially what I would do is I'd wean the steroids in the same sort of weaning protocol that we would use normally. I then keep them on mycophenolate between 2 and 4 weeks later. If their function, whatever it is, whatever their toxicity remains completely quiescent, then I would look at stopping them after a month. That would be sort of my normal rule of thumb. So I stop the steroids first, carry on with the additional immunosuppression. But most patients manage to get off their additional immunosuppression as well. I would say probably less than 1% of my sort of additive patients have needed long-term immunosuppression with a second agent. But that would be my approach. So a standard approach to steroids, see if they maintain their toxicity-free status, and then stop their second immunosuppressant. Would be my standard.
So I guess a natural question, Anna, from that is, we talked a little bit about infliximab and that story with hepatitis earlier. We've talked about mycophenolate and where that fits. Have you got go-to second-line immunosuppressive agents based on the toxicity?
I do, yeah. So it's quite interesting. So I tend to use more of a tempo rather than a specific toxicity. Colitis probably sits slightly apart from that because of the huge use of biologics by the IBD community. So I think that probably is the one that sets outside of what I'm about to say. But other than that, generally speaking, I would use Mycophenolate, if I've got a patient who is gradually improving or plateauing or doing that sort of flaring at low doses, mycophenolate is a good drug, but it takes at least 3 to 7 days probably to see any benefit. The reason being is it impacts on the creation of new T cells, doesn't really have any impact on the existing T cell population. So getting an effect from mycophenolate quickly is something you won't see even at relatively high doses. So I would standardly use an in-reach of 500 milligrams BD and go up to a gram BD as standard. There are some patients you can go up to 1.5 grams, but they get quite a lot of gastro side effects. So I tend to sit around a gram BD. If you've got somebody that's smouldering, would be my description of it, then mycophenolate is a good go-to. If you've got somebody who is needing a much quicker response, so if you've got somebody whose numbers are going off, if their LFTs are going off, or you're not getting any traction with your steroids, or you've got a myocarditis patient who's really, really flaring quite quickly, and you're not really getting benefit from steroids, then my go-to drug is tacrolimus, because actually that works on existing and new T cell populations. So you see an effect normally within 1 to 2 days. We would go with oral tacrolimus. We don't see in IO any particular benefit from using IV. And generally speaking, we use a starting dose of 3 milligrams BD, and then we aim for a level of around 10 using trough levels. And I find that phenomenally helpful. Tacrolimus works really, really nicely in IO toxicity when you need a rapid response. And then my go-to biologic is infliximab, and I'm using that more frequently. So my normal rule of thumb is if they're quickly progressing, steroids. If you get a response, great. If you don't, add in tacrolimus. If you don't get a response from that, add in infliximab. And I do that for pneumonitis and myocarditis, as well as my colytics. If you've got somebody who's smouldering along, steroids and then MMF. I will sometimes add in MMF as well as tacrolimus depending on the process. So that's my sort of rule of thumb at the moment. I think in the next 6 months to a year, we're going to see a real sort of question about things like tocilizumab, particularly given the fact how beneficial it's been in COVID. So is anti-IL-6 routes the way to go? With Tofacitinib looking at the IFN gamma processes is something that we may well see a lot of. Also, it's an oral drug, so that's got really attractive elements for us. Are we going to use vedolizumab more? So there are lots of new agents that are better at controlling the immune system, but they are much more complicated in terms of the finance and the commissioning. And I think that's going to be our biggest challenge yet, is working out what to use and actually how we're going to get it paid for. But that would be my current process of how I approach toxicity, and it's all tempo related, really.
Just on the tacrolimus, Anna, because I don't have much experience with it, is there any side effects that you have to worry about? Is there anything you need to keep an eye on?
If you have got, so the biggest challenge with tacrolimus is working out where you're going to get your levels done. So, for example, if I'm treating patients in North Wales, then levels have to go to Bangor, and it's a 4-day turnaround. So there are some logistical challenges with tacrolimus. As long as you are level driven, then actually the side effects are generally quite low and not particularly notable. And I find it's better tolerated than MMF in terms of side effects. But you have to make sure the levels, obviously, if you can't monitor levels and they become toxic, then yeah, they get horrible side effects and neurotoxicity and confusion and things. But it's actually relatively easy to titrate, and patients tolerate it really quite well. So I find that immunotherapy toxicity patients respond really well to it, and I've seen response even in those complex toxicities like myocarditis patients and pneumonitis patients respond nicely to it.
Right, that's really, really useful. Mindful of time, should we try and do one more each?
Yeah, that's fine with me. Dan, is that okay?
Yeah, that's fine. I think we can go by 5 minutes today.
Thank you. Okay, so Ricky, I think one of the problems we have quite a lot is that there's quite a lot of still lack of awareness of these toxicities. So what do you do if you're sort of on the phone to somebody who's rung you about a patient who's gone into a different hospital, and there's a bit of concern or reluctance or skepticism about treating them, particularly with IV steroids and relatively good going immunosuppression? What do you do, and how do you tackle that?
So I think first of all you need to be open and honest. It sounds obvious to say, but often we're all using experience or case studies or consensus. There isn't a great deal of randomized controlled data, and oncologists love randomized controlled data. So I think it's showing them the guidelines is really useful, showing them MESMO guidelines, UConn's guidelines, chatting it through with colleagues. So you'll know that I'll often ring you or somebody else just to chat the case through. I think we should never be too proud to do that, just to say, actually, can I get some more thoughts on this? What would you do? What would you do next? And I think also accepting that they will be a little bit threatened initially when you're speaking to a GI specialist and saying, can you give infliximab? So I change that conversation and say, actually, this patient needs some additional immunosuppression. You know, what kind of drugs can we use? You know, infliximab, vedolizumab, what's your thoughts? You know, can we get a scope? Do you think that will help? I think it's a little bit like the radiology discussion. It's going down to radiology and saying, I need a CT scan, and they're likely to tell you no. Or you go down and say, you know, I could do with a scan, what do you recommend? And they go, well, I think a CT scan. And you go, well, that'd be great. So I think it's just having sort of sensible conversations and making them feel like genuinely you're co-creating the plan. Because in reality, none of us know exactly the right thing to do. And we all come with different skills and different knowledge bases.
I think that's absolutely true. I think there are a couple of the tools that you can use in your arsenal. So one is that increasingly there are specialist guidance written by the sort of toxicity, the parent organ system. So I find it quite entertaining. So, you know, the gastroenterologists have written guidelines. They look identical to the oncology ones, but they've been written and worked on by gastroenterologists. The Society of Endocrinology have done the same for endocrinopathies, and there are more coming. And I think, quite understandably, you know, I am not a gastroenterologist, and I think it's very reasonable that gastroenterologists have a problem with an oncologist telling them how to treat a colitis. I actually didn't think that's I think that's very reasonable, but it's useful to be able to say these are your guidelines, so it might be worth looking at them and seeing if you're more comfortable with them. The other thing is, if you've got friends in the region, so if you've got a friendly gastroenterologist that you've made your friend, often if that patient is in another hospital, what I've done is rung my gastroenterology colleague and said, there's a patient in X hospital and the gastroenterologist is sort of quite unsure as to what to do. Would you mind ringing them rather than me? That's worked really well, where they've had a conversation about what gastroenterologists are doing amongst each other. And it's not just gastroenterologists, it's true across the board. So I think because what you find is that these patients aren't sort of a classical oncology toxicity, neither are they classic ologist toxicity. It's not a classic hypophysitis, it's not a classic colitis. And so what you tend to do when you find colleagues that you work with alongside quite frequently is you get joint learning. And certainly, you know, with the cardiologist, for example, I do the immunosuppression and they do the beta blocker and the ACE inhibitor and whatever else that they do with its magic that makes the heart work better. And that works really nicely. So we tend to do that sort of partnership management quite frequently, so that actually the patient's getting the best of both worlds. But the kind of, you know, the worry about taking oncology advice about a specific organ, I totally understand, and can be sort of managed by sort of using some of those tools. There's also a really good 8-page spread in the I think the Journal of Emergency Medicine about checkpoint inhibitors. So I find that really useful for our ED colleagues to say, worth having a look at, just so that it's from their perspective rather than mine.
And then a final question for me. I really like your fatigue sort of crib sheet. So yeah. I guess some of them are fairly straightforward, but I don't check zinc levels. I don't routinely do vitamin D. So just a little bit of an idea about that and who we should be doing that for.
So I think the answer is slightly different for both of those. So the vitamin D levels I would do in everybody. The amount of the UK population that are vitamin D deficient is amazingly underreported, and so I do vitamin D levels in everybody that's fatigued. In terms of zinc, it's very rare that I do it. So I only do it if patients are describing nail or hair wiriness, for want of a better description, where it's become quite brittle. That's quite characteristic of zinc deficiency, and I've certainly had 2 or 3 patients where we've replaced it and they've improved from a fatigue perspective. The biggest element I find is that we get a lot of iron deficiency patients who aren't yet anemic, and I think it's probably because we sort of get them into a chronically low level inflammatory state, and so they do deplete their reserves of various sort of hematinics. So we do find people who are B12 folate deficient, but that's rarer. But I have a lot of patients that are iron deficient who are iron replete before we started immunotherapy. They respond really well, particularly to IV iron replacement, and their fatigue improves significantly. So I do think it's surprising how many patients with fatigue that we can reverse. Obviously, we need to make sure they've not got an endocrinopathy. And hypogonadism, particularly in males, they feel really fatigued, and testosterone replacement is easily done. So there's a few things you have to be careful. They don't have a concomitant prostate cancer, and they haven't got a normal testosterone for their age, are the two sort of things I would be aware of. But I would always check testosterone in a fatigue person. And as I said, if those things are negative and the patient's still describing significant fatigue, then I would be quite inclined to check a cardiac panel now, because of the number that I've picked up. And in that 100 patients that I described, we looked at baselines. Everybody goes, oh well, fatigue is quite a wide thing, so actually it's probably everybody. But if you look at the incidence, I had a 5% incidence in the patients that didn't have myocarditis, and a 95% incidence of fatigue in the patients that did have myocarditis. So actually most patients on immunotherapy aren't fatigued. Obviously, if you've got somebody who's got a really significant malignant burden who are fatigued before they start, it's not helpful. But a new fatigue that isn't getting better, I think, is really well serviced with the fatigue screen. It doesn't cost very much, and actually if you can reverse those things, it has a really significant impact on quality of life.
Fabulous. So before Dan implodes, I'll hand back to Dan.
So thanks very much both. It was a really interesting discussion. I mean, I think, we could all discuss this all night, and, pretty much everyone who's logged on has stayed with us. So that just gives you an indication of how helpful it's been.